Assalamualaikum and very good morning. So today I'm going to give you a brief lecture about lower limb block. As we all know, lower limb, we cannot run away from take consideration about the lumbar and the sacral plexus. So for the lumbar plexus, it started from L1 to the L4, whereas the sacral plexus within the L4 into until S3. So then this slide shows the innervation of the lower limb. So as we all know from the infront, most of the nerve that cover the infront is femoral, obturator, lateral femoral cutaneous, and where at the back, mostly by the sciatic nerve. Okay, so we go about the femoral nerve block. So what is the femoral nerve? Femoral nerve is the largest branch of the lumbar plexus, whereby it's from the L1, from L2, L3, and L4. Descend through the fibers of the psoas muscle, emerge underneath the inguinal ligament into the thigh. It's divided into anterior and posterior division. This is important when we want to talk about the popliteal block later. So at the femoral creases, the nerve is covered by the fascia iliaca. Femoral nerve separated from the femoral artery and vein by a portion of the psoas muscle and the ligamentum iliopectinus. It prevents spread of the local anesthetic when performing blind paravascular technique. Alright. So what are the surface anatomy? So as we know from the femoral crease, from the medial to lateral is VAN, vein followed by artery and followed by the nerve lateral to the artery. Okay. For the ultrasound guided technique, femoral nerve easily visualized using linear probe. Onset time is quick. It's almost one of the simplest block to do. How much to give? About 15 to 20 minutes of LA. Alright. So this one show the how we do the femoral nerve block. Patient in supine, we put a linear probe, okay, at the femoral crease. What you want to see is, you see the femoral artery, okay, lateral to the femoral artery is a femoral nerve, right? Same, this diagram also, femoral artery and also the femoral nerve. This is the upper part of above artery and also the nerve. This is fascia lata. Below the femoral nerve is fascia iliaca, alright? Okay, if you see this picture, this is like a Mickey Mouse sign. It means that you are too lower. You should push your probe up until you see artery, vein, and the nerve. Your aim is to give your needle into here and then deploy your local anesthetic at the lower end and also the upper part. You can see from this video, this is a fascia iliaca and this is the femoral nerve. The needle came from the lateral side, okay, squeeze around the fascia iliaca and deploy the local anesthetic. Now the femoral nerve been pushed downward. So you can give about 15 to 20 minutes of local anesthetic here, alright? But you have to remember this one only used for analgesia because the local anesthetic only deploy at the upper part. If you want to use for the anesthesia, you must deploy local anesthetic. Okay, we run back the movie. This only deploy the upper part. Okay, you can withdraw back the needle and deploy in the below side to get the better coverage. Okay, that's all about the femoral block. Next one, we will talk about fascia iliaca block. So what is fascia iliaca block? Classically famous with 3-in-1 block, whereby you aim to block lateral femoral cutaneous, femoral, and obturator. It was said is the best option for the hip fracture primarily. Okay, so the fascia iliaca compartment is a potential space with the following limits. Anteriorly, the posterior surface of fascia iliaca cover iliacus muscle and with the medial reflection. Alright, posteriorly, anterior surface of the iliacus muscle and the psoas major muscle, medially vertebral column, and craniomedially continuous with the space between quadratus lumborum block. Okay, for the facade iliaca block, right, there's two ways to give, either supra-inguinal or below inguinal facade iliaca. With the current latest guideline, the supra-inguinal facade iliaca is better coverage as compared to the below inguinal facade iliaca. So what are the coverage? You can see the facade iliaca coverage almost all the anterior compartment of the anterior thigh. Okay, and also with the medial side of the shin, right? For the bony coverage, almost all the femur, right? Okay. So, how to do supra-inguinal facade iliaca? Right. First, you must to palpate for the ASIS, right? Patient in the supine position, you palpate the ASIS. You use a linear probe, right? And perpendicular, about 1 or 2 finger breadth lateral to the ASIS. So you aim to see what the textbook sign called the bow tie sign. This is the bow tie sign. Okay, this is the intra-oblique muscle and this is a sartorius. Okay, so this one also the same. This is intra-oblique muscle and this is a sartorius. Your aim is to give the local anesthetic below at the bow tie sign. Alright. Okay, you can see from this video, right? So they put here is the iliacus muscle and here is a facade iliaca. Here is anterior inferior iliac spine. You can see here the deep circumflex artery also. Sometimes you can notice the deep circumflex artery. So where is the needle? Needle came from the caudate. Here is the needle. Try to squeeze through to give around here below the artery. So this one is a little bit overshoot. So the needle will retract a little bit and try to give the locus around here. Okay. Now the test dose was given, but however, it's not into the facade iliaca. Alright, this is going into the muscle. So what we need to do is we need to withdraw back a needle and reintroduce your needle again. Right? So we withdraw back the needle. Okay, again, we want to give the fascia here, which is below the artery. If you can see the artery, is very good. Sometimes you cannot see the artery also. It's okay. Okay, now you can see the pop there. Yes. Now, after you give, the local anesthetic spread nicely. Okay. Sometimes people say this is a zipper. It's like a zip. When you give, it's open up. Right? How much to give? About 30 to 40 ml of your LA. Alright, so that's all about the facade iliaca. Lastly, we go for the popliteal approach of the sciatic nerve block. As you all know, sciatic nerve block, you have a lot of approach. You have transgluteal, you have subgluteal, and you have the popliteal approach. Okay, this anatomy show the sciatic nerve. Before it reach into the popliteal fossa, is divided into two, tibial nerve and also common frenulum nerve, right? So what is your aim of giving the popliteal block is before it bifurcation. So roughly about above the, traditionally it's mentioned above the popliteal fossa about 10 centimeter. However, by using ultrasound, it's just above, sometimes about 2 cm or sometimes is lesser than that, right? So popliteal sciatic, what are the coverage? The coverage normally below the knee, okay, on the lateral aspect of the shin until at the toe area, almost all covered by the popliteal sciatic block. Alright, again, So you can see from here the diagram. Next to the bifurcation is a bicep femoris, and then you have the nerve coverage. So you aim to give before the bifurcation. So indication, foot and ankle surgery, vascular surgery at the foot, for lower limb angioplasty, anesthesia for posterior knee surgery, right? That's the indication. So how to give? So there are few ways of giving popliteal sciatic. Either patient can be this one patient in prone, whereby this one patient in lateral, and some people use a technique whereby patient in supine, they support the knee with sometimes we can put what do you call it, a pillow there to support your knee. Okay, so from the diagram, how to scan for the popliteal sciatic nerve. Okay, you use a linear transducer, put at the popliteal crease, all right? At the popliteal crease, what you aim to see is the artery. Okay, you can see the artery, and normally the nerve is above the artery. Okay, but this one you're not sure because this already bifurcate. What you need to do is you need to move your probe upward carefully. Okay, when you see you move the probe, you can see the other part of the nerve also appear until it merge. Okay, when it merge, this is the site for you to give your popliteal sciatic block. All right. Can we give before it merge? Can, but you have to deploy your local anesthetic to different places. Okay, this one show how to give in anterior approach. All right, it's a probe. The needle is distant away. You can see the needle come from here. This is the popliteal sciatic, right? So you aim to give inside. Sometimes you can see the. Okay, now they deploy already local anesthetic. So local anesthetic, we go around here, right? We give in the upper part first. Okay, we deploy about 20 mils here, and later on we give at the lower part. So our aim is to encapsulate the local anesthetic around the sciatic nerve before the bifurcation. Okay, you go in the below, right? Then they deploy the local anesthetic there. Okay, I managed to go inside already. Then deploy the local anesthetic. So now you can see the nerve is appear to be floating by the local anesthetic. All right. Okay, that's all. Thank you.